I'm Dan Pollier from the University of Colorado, where I direct the Leukemia Service, and I'll be moderating today's tumor board. And I'm joined by some of my colleagues from around the country, and I'll let them introduce themselves, starting with Dr. Kamdar.
Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado, and I lead the lymphoma program there. Glad to be here.
Hi, Tyler Fromm. I'm an assistant professor of radiology with appointments in both abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri, and I'm happy to be here as well.
Hi, I'm Michael Thurman. I am an associate professor at the University of Chicago, section of hematology oncology. I focus on hematologic malignancies and in particular leukemias.
Keep going with the lymphoma theme and talk about a difficult category of lymphomas, the peripheral T-cell lymphoma. In this case, this is a CD30 negative patient. So this is a 60-year-old female with recurrent fevers and lymphadenopathy who is found to have hemophagocytic lymphohistiocytosis, HLH, as well as a newly diagnosed peripheral T-cell lymphoma. So definite challenge, something that we do see, but lots of difficulty here in addressing these conditions. So the patient comes in with fevers, night sweats, weight loss, peripheral swelling, headache, and cough. Performance status still 1. So this patient had unicentric Castleman disease, had a splenectomy with a distal pancreatectomy, also Takotsubo cardiomyopathy, hypertension, hyperlipidemia, diabetes, nothing on social or family history. Specifically in 2011, diagnosed with unicentric Castleman's disease. And Dr. Kamdar, do you find that Castleman's can be a precursor? That is not a malignancy per se, but can that be a precursor to other sort of lymphoid malignancies?
It can be. I think it also depends on if it is unicentric or multicentric Castleman. Unicentric Castleman is certainly a benign entity, which is typically treated with surgical excision. That's what the patient got treated with. If it's multicentric, then it really depends on whether it's HHV8 mediated, if it is SPOMS mediated, if it's idiopathic multicentric, and then the therapies can be very variable and very different.
So 10 years later, the patient has similar symptoms. The workup is largely non-diagnostic. The assumption is that this is recurrent to the Castleman, so the patient is treated with prednisone, and then the symptoms recur. Maybe Dr. Fromm can take us through these images here.
Yeah, so on the left side, on the top, we have transaxial CT images through the lung bases with a lung window showing sort of moderate-sized bilateral pleural effusions with some passive atelectasis in the lung bases. And then lower left there, we see an image through the upper abdomen with a small volume of perihepatic ascites, and tough to tell on this image, without having kind of a coronal to sort of measure, but perhaps a little bit of hepatomegaly in this patient as well. And then on the right, the single transaxial image, a little bit lower through the abdomen, sort of post-contrast image, showing multiple lymph nodes within the small bowel mesentery, as well as some mesenteric edema. So I think the possibility of recurrent Castleman's disease, with kind of a multi-centric process would be possible here, but the lymph nodes, in that setting, tend to have a pretty characteristic, like markedly hyper-enhancing appearance. They tend to sort of enhance almost as brightly as the vessels, and in this case, these lymph nodes don't. They're sort of enhancing more similarly to the skeletal muscle. So radiographically, this would not be a great look for recurrence of Castleman's disease. So I think other hematologic malignancies would certainly be high in the differential. In terms of the the effusions and the ascites, the hepatomegaly, certainly the hepatomegaly could be involvement by hematologic malignancy. I think in this patient, we know that there's HLH as well, and these are sort of the typical imaging findings that we see. They're not specific by any means for HLH, but hepatomegaly, pleural effusions and ascites are some of the most common things that we see in the setting of HLH. So those are kind of the things that I would take away from the images that were provided here.
Great, thanks. Yeah, I mean, HLH, as we'll talk about, can be so hard to diagnose. Any input from any of our colleagues is really helpful there. So this patient goes ahead and gets a CT-guided biopsy of one of those retroperitoneal lymph nodes, and they are diagnosed with a peripheral T-cell lymphoma. And you can see some of the different immunohistochemistry stained here. This is a quite proliferative disease with a Ki-67 of 90%, negative for CD30, as we heard during the opening slides. And in addition, HLH is made based on the criteria from the list below: fever, cytopenias, the triglycerides, ferritin, elevated soluble IL-2 receptor, and low NK cell activity. Low-level EBV viremia, and as if that's not enough, DVT, GI bleed, COVID, and bacteremia. So lots and lots, unfortunately, going on for this patient. But Dr. Kamdar, maybe you can help us to sort of put this all together. Sometimes, which came first, the HLH, the lymphoma, how are they related? And then anything, maybe you could try to tackle that one for us, and then maybe just take us through the biology that we're seeing here of this T-cell lymphoma and what stands out to you and how you would put it together.
I think, first of all, to get to a diagnosis of HLH requires a very high index of suspicion. And by then, the tempo of the disease is picking up, the patient is getting sicker. So by the time we get consulted on patients like these, they are usually doing fairly poorly. So I think something to really bring to light here is to get the diagnosis of HLH. And then at this point, it's important to understand, based on his age, it's probably going to be secondary HLH, secondary to either infection or inflammation, rheumatologic conditions, or malignancy. And in this case scenario, as Dr. Fromm alluded to, based on the CT scan and the biopsy that was done, this seems to be secondary to T-cell lymphoma. HLH and T-cell lymphomas, there are multiple case reports of the literature that have certainly shown that the T-cell lymphoma can trigger massive inflammation and thus HLH. So the big question is, how do we really want to treat this patient? Usually in patients where the HLH is secondary to a malignancy, treatment of the malignancy will take care of the HLH. So coming to treatment of PTCLs that are CD30 negative, this is where the challenge kind of thickens and even further. At this point in time, for patients with T-cell lymphoma that are CD30 positive, the regimen of choice is brentuximab CHP based on the Echelon-2 study, wherein it showed superiority over CHOP. However, in a T-cell lymphoma that is CD30 negative, I would not use brentuximab. So then I'm really left with CHOP. In a patient with a prior history of Takotsubo, with an ongoing COVID, with bacteremia, with recurrent GI bleed, at this point in time, I don't quite feel strongly about introducing full dosing chemotherapy. I think I would probably just treat this patient to start off with HLH 94 protocol, which would be a combination of etoposide and dexamethasone, while the other conditions are being managed. This is an 8-week regimen with tapering doses of dexa as well as etoposide. If he did not have the concurrent peripheral, pretty major other comorbid conditions, then in that case, I think I would probably go with something like CEOP, spare him the anthracycline based on his history of Takotsubo cardiomyopathy. If his EF is preserved, then too, I think I would be fine with just CEOP for now and see how the patient does. It's certainly a very complicated case, and I don't think there are any clear answers. One can defend CEOP, one can defend CHOP, and one can defend just the HLH-94 protocol. But I think the baseline here is to get the patient feeling better and get his cytopenias and all of the other symptoms a lot better before we then embark upon full therapy for PTCL.
That was great. Thank you for your very cogent explanation there. That was really helpful. I think if I had to summarize this extremely challenging patient with a T-cell lymphoma and HLH, then I would probably say that treating the lymphoma will hopefully treat the HLH, which is likely secondary to the lymphoma in this case. Not having a CD30 directed therapy limits our options greatly. And so, depending on the severity of the comorbidity, particularly the heart, a CHOP type regimen or CEOP, or just the HLH regimen that you mentioned, the etoposide plus steroids, may be enough to get this patient into a situation where they can tolerate a more intensive regimen.